Before introducing our speaker, a quick word about the Prostate Forum of Orange County. The forum is a group of men who themselves are dealing with prostate cancer and who want to support anyone else who is dealing with the disease. We do this by offering information, education and hope through our website, prostateforum.org, and through monthly support group meetings and presentations by experts. There are 2 online support meetings each month. The first, mainly for those newly diagnosed with prostate cancer, meets on the 2nd Tuesday of every month, and another meets on the 4th Tuesday of each month, mostly focused on advanced and recurrent prostate cancer. Both meetings are free and open to anyone affected by prostate cancer. In addition to these support groups, we also offer on most months talks by experts in the diagnosis and treatment of prostate cancer, just like tonight's presentation. Topics from these experts range from diagnosis to active surveillance to radiation, surgery, side effects, genetics, and other medical advances. You can learn about upcoming presentations at prostateforum.org/speakers or view previous presentations at prostateforum.org/presentations or on our YouTube channel at youtube.com/@prostateforumoc. To take advantage of these resources, we encourage you to sign up to receive announcements of meetings, presentations, and newsletters. And when you're ready, please consider helping us help others who are dealing with cancer. We're all volunteers, and we invite you to volunteer some of your time and expertise with organization, coordination, marketing, website maintenance, whatever you can. Whatever you can give will really help. And even though our volunteers are not paid, our expenses are very real. Your donations will help us to continue providing education, information, and hope to men with prostate cancer and their families and friends. With that, let's turn to tonight's speaker.
Good evening, everybody, and welcome to the Prostate Forum of Orange County, California. Tonight we have a special presentation, special in the sense that you get to watch history in the making. And I don't just mean for prostate cancer, but across all platforms in medicine. We are joined tonight by a very special guest who is an international expert in the management of prostate cancer and the development and validation of prognostic and predictive biomarkers. He has published over 300 peer-reviewed manuscripts and runs a National Institute of Health funded translational laboratory. He is chairman and professor of radiation oncology at University Hospital Seidman Cancer Center and Case Western University. Without further delay, we are honored and excited to welcome to our presentation the role of genomics and AI in the personalization of prostate cancer care. Please help me welcome Dr. Daniel Spratt, MD. Dr. Spratt.
Thank you so much. This is, prostate cancer has changed so much. And I wanted to sort of actually start giving you I'm a radiation oncologist. That's my practice. And I wanted to just show you just in that management, how much things have changed. And that sort of dovetails into this talk about genomics and artificial intelligence and what we're doing. But, my purpose, and I hope any doc you guys see, our job, to put it nice and simply, is to improve the way you guys or patients experience life. That's it. It's not just about PSA. It's not just about, trials and drugs and therapies. It's about, do you experience life better to you? And each patient will define that differently. And to kind of oversimplify things, but for men with newly diagnosed cancer that we believe has not spread anywhere, there's things that we commonly do. Active surveillance, where we monitor, we might defer treatment, not treat immediately. You can have surgery, the robotic surgery. You can have modern radiation therapy. This is called a linear accelerator. And then there's a whole laundry list that I put these caution signs, not to say these can never be primetime therapies, but these are experimental. Usually you have to pay cash for, and usually they're recommended to be done on a clinical trial. So for low risk prostate cancer, low grade prostate cancer, trials have shown that all of these these three on the left are equal. So why would you want to undergo this operation or this radiation if you can just watch it? And that's why active surveillance is what's recommended. As you move up into more, we call it clinically significant prostate cancer, some people call it intermediate risk prostate cancer, trials have shown that, the long-term outcomes are the same, whether you have surgery or radiation. And so it's about, for you or for the patient, what's best for them, for their quality of life. And to kind of show you how rapidly things have become disrupted, I just want to take you guys back, because I think sometimes patients, especially patient advocacy groups, they've talked to, whether it's primary care docs or urologists or oncologists, or they had fathers, brothers, and to show you kind of up until the 1980s, this here on the left, think of it, this is just an X-ray. It's like a plain film. This is the pelvis. They didn't have MRIs and CT scans really. And so this little box here is how they guided radiation, and the prostate's there, but all that healthy tissue is there. And so it was just blasted through the guy. This is, the technology they had at the time. And what I'm showing you here is that about a third of guys had bothersome rectal bleeding. So whenever a doc says, or a patient says, my doc said, is radiation going to burn my rectum? It tells me exactly how old that doc is, because they got to witness this. In the 1990s, sometimes 1980s, but 1990s, maybe some centers carried it into the 2000s. We finally had we call it three-dimensional imaging, right? This is a CT scan. It's a slice through the patient. The top here is the front of the patient, like your belly. The back here is your backside. These kind of white things here, these are your top of your kind of your femurs, the top of your leg bones. And this thing circled here is your prostate. And we could make these things called a 4-field box, a little box to make it a little more accurate. The rectum's right here, it got dosed. But just by this sort of advancement, you can see here, and this was from that randomized trial of surgery versus radiation versus just monitoring, this little orange blip here was the radiation patients. They had worse bowel function that usually resolved with this old technology. But so about 8% of guys instead of 30% had some type of bad rectal toxicity. And then this era and the million acronyms that confuse patients was called IMRT. But think of it as it's leveraging computers now to say, how on earth do I get the dose to the prostate and not the rectum or not the bladder? And this has been pretty standard of care at any normal major modern hospital since the 2000s. But you can see here, it allows us to sort of bend or shape. Again, this is the prostate, right behind it's that rectum. You can bend and shape most of the dose out of that rectum. But you can see the top of that rectum there still gets some of the moderate dose. And this is showing you just the high dose. So you can see that high dose skims the top of the rectum. But in this advancement, you're now down to about 1 to 3% of guys would have, it's called a grade 3, a bothersome rectal side effect. But it took 2 months. And you guys may have heard of guys that get 45 treatments over 8 weeks, 9 weeks. And then a couple devices have now been approved. One is the spacer gel. There's another company called Berry Gel, but these are these gels that can be, basically just through a needle that get inserted, and it creates this space between the prostate here and the rectum here. And this is one of, my patients that the rectum is shown here, and the spacer gel is this thing in pink. Not even that, moderate dose even touches the rectum, and the high dose is nowhere near it. And so, back in 2016, it got FDA approved. So there wasn't any high grade toxicity and not even moderate grade toxicity. So this to me is, my standard practice for men. And this was just showing you from the trial that got the device approved. No men had even a grade 2 rectal side effect. And we were super excited. A little over a year ago, we were the first center of excellence in the world that we have just a very high volume, really a program focused on quality of placement of these gels and using sort of the new gel that has a little contrast in it. So this is, again, a patient, you can see their prostate here. That gel is right here, and this is their rectum. So it's kind of this nice plane. And what that's allowed, some of you may have heard of something called SBRT, another lovely acronym, but it's 5 treatments of radiation. And so about 90% of my patients, we do in just 5 treatments now, because we, through all this technological advancements, we are able to be far more accurate and far more convenient. There's no way in my busy life I could go take 9 weeks to get radiation, or it'd be challenging. So this has been a big game changer for patients. And this is just, this is on the academic side, but this is just some of the really big trials conducted around the world, showing that whether you give that 8 weeks of radiation in the blue curve, or the short course in the red curve, very similar chance of side effects. So it's not like the short course is more side effect. And this is a European study. It's very confusing here, but if you focus down here, the triangles, the blue is the 5 treatments, the red is like 20 treatments. Almost no men had a bothersome side effect, and even just a moderate side effect, regardless of if you had 5 treatments or 20 treatments, it's basically the same. So what's happened is they just reported this. It's not published yet, but it was presented that they did a randomized trial of surgery, or the prostatectomy, versus that 5 treatments called SBRT. It was done in the United Kingdom, because in the US, I don't think any of my patients would be willing to get randomized and not get to pick the treatment they want, where someone tells them. But what this is showing you is, the chance of having incontinence after surgery, ranged obviously right after surgery very high, but at 2 years out, it was about 40% of guys had to wear at least 1 pad a day after surgery, and as expected, almost no men after the 5 treatments of radiation. And the bowel side effects, you can see here, 0% of men after surgery had a moderate or big problem with any bowel problems after surgery, as we would expect, and only 1 guy had it after radiation. So when you think back to those studies I showed in the 1980s, it's really remarkable how far we've come. And what's really, again, for about half of men over the age of 50 have erectile function. So some, I think sometimes men don't realize how common erectile dysfunction is, even in 50-year-olds. But you can see in the green, these are the guys that got the 5 treatments of radiation. Even by 2 years later, only 12% of guys had a hit to their erectile function, whereas with surgery, it was, well over half of them. So this is one example of advancements that's happened through technological advancements, where now, we're doing more radiation therapy than we ever have done before, because we can now give effective doses, so to be as effective as surgery. We can avoid the incontinence that some men, not all men, experience with surgery. And thanks to the technology and things like that spacer gel, we can really avoid those rectal side effects. And while radiation can definitely still cause erectile dysfunction, the rates are lower than most treatment. And it's now a lot more logistically feasible, right? 5 outpatient treatments. The radiation beam is actually only on for about 6 minutes. Most guys, it's 30 minutes door to door in the department. And obviously, for those patients who are averse to having catheters or anesthesia, they don't need that. So this is to give you that evolution, which this occurred over 40 years from this treatment, where we basically radiated everything, to this nice precise treatment. But this is sort of half the story, is that now that we no longer treat usually low-risk prostate cancer or low-grade prostate cancer, we monitor it. As you get higher grade cancer, we often will add something called hormone therapy to radiation, and that has its own pros and cons. Why do we add it? Well, we add it because it's been shown, especially in high-grade prostate cancer, to increase the chance of cure, reduce the chance that the cancer will later spread, and has been shown consistently to help men live longer. I'm sure many of you are familiar that ADT, which is another name of hormone therapy, androgen, testosterone is an androgen, and we're depriving it by, it usually tells your pituitary gland in your brain to tell your testicles, stop making testosterone. And why on earth are we chemically castrating our patients? Well, prostate cancer feeds on testosterone. It's a fuel source. So it's very effective at stopping prostate cancer from growing. But as you see in this figure, it's got a lot of metabolic effects, can increase blood sugar, increase body fat, lose some muscle mass. A lot of these on the right, and some of these on the left actually have been shown, and I can't emphasize this enough, that physical exercise can actually counteract many of these. So I prescribe all of my patients 10 minutes of physical activity a day if I give them hormone therapy. And it doesn't need to be going to a gym, but some balance of, whether it's walking around, I'm in Cleveland, shoveling snow, whatever it may be. But that usually can counteract many, but ADT, depending on the duration, definitely does have side effects. So I would say that consistently studies show that that's probably one of the number one things men hope to avoid. And so we really wanted to understand, do all men really benefit from hormone therapy with radiation? And so what this study is this is a global initiative of basically every major trial group in the world sent it's a consortium I lead called MARCAP, but it's to see what's the benefit of hormone therapy with radiation. And you can see here, in the US, it's called NRG, but from Australia and Europe, all of these trials that have been done in patients sort of sent us all of their data. And for men that we often add what's called a short course of hormone therapy with radiation, this number, and I'll explain what this means, the number needed to treat is 18. And what that said another way is if I treated 18 men with hormone therapy and I added it to the radiation, I would prevent one man from developing metastatic disease. So you can think of that as, and in medicine, that's a very good number in the sense that no treatment do we have that every patient we give a therapy to benefits. But that also means that 17 of those 18 men did not benefit from that hormone therapy, okay? But this is kind of the accuracy we have if you look at the national guidelines and how we decide who gets hormone therapy. This is, giving homage to Dr. Gleason, who created the Gleason system. Many men, when you get diagnosed, you'll get a grade of your cancer. It used to be only called the Gleason score. Now they've got some other ways of reporting it. But a lot of us, and doctors too, okay, and I would say doctors have been completely brainwashed by the Gleason system. And why do I say this? And this is of no disrespect, because Dr. Gleason's done amazing things for the field, is when you look at what was created, this is what the Gleason system is. It's how do those prostate glands look under a microscope when you get your prostate biopsy. There's nothing about this system that tells you, is your cancer more aggressive or less aggressive? Is it more responsive to surgery or radiation? Do you need hormones or not? But it happens to be that the cells that look like this tend to be a little less aggressive, and the patterns down here tend to be more aggressive. But by no means was this designed by Dr. Gleason to say, what exactly are the patterns that tell you which men have actually aggressive disease or not? And I guess another way to put it is, if you took a group of people that are 300 pounds, some of them will be great at football and be linemen. some of them will just be fat and out of shape. And you can see patterns to say if you saw a bunch of 300-pound people, you're probably more likely to find some linemen than if you only saw a bunch of 100-pound people, but you're not going to necessarily be perfectly accurate. And that Gleason system has evolved all the way in the most recent iteration about a decade ago, but it really hasn't changed that much. Okay, it hasn't changed that much to tell you exactly the treatment you need as a man. And I put this really busy slide up simply to show you that from about the 1950s to about 2016, doctors have been inundated with all sorts of staging systems, the D'Amico risk groups, the Gleason groups, the NCCN risk groups, all these things. But what's really important for patients to realize, and many doctors don't realize this, is none of these systems were actually trained to precisely tell a man how aggressive is your prostate cancer. But I can promise you, if you read most sort of either lay texts or many even medical books, they'll try to tell you that these risk groups, these stages, these grades are very accurate and tell you do you have aggressive or non-aggressive disease. And I'll talk about a couple of these newer systems that have come out that are really actually either using genomics or, as I'll talk a lot about, the artificial intelligence work, that are actually trained to take men who did not ever develop metastatic disease and men who did develop metastatic disease to actually look at their tumors and more accurately tell you, which is which. And so to kind of drill the last point home, we wanted to further sort of give data to this point in that we took 10,000 men that were enrolled on randomized trials across the US. And we wanted to look at Gleason score, okay, that's red here. And what I'm showing you is, this is called an area under the curve. And I apologize for all the weird stats, but just think of here at 0.5, this is a coin flip. If I had 100 guys in my clinic, if I flipped a coin for each one of them, that coin would be right half the time if that man would develop what's called a biochemical recurrence. Would their PSA rise after I treated them? Gleason score, PSA, your T stage, how big the tumor, extensive the tumor is in the prostate, and your what's called your risk group are barely better than a coin flip, okay? And the reason is that none of these were actually trained to precisely tell you which men will recur and which men won't. So we've got a lot better tools out there, right? Cancer at its core is a genetic alteration or a mutation or some sequence of events. But we aren't, in clinic, when you get a PSA or you get that biopsy or you get that MRI, you're not looking at the genetics. You're looking at something very downstream. People will call it the phenotype, the grade of the cancer. What does it look like? Or on MRI, what does it look like? And these are subjective. You guys may have heard that you send your tumor to one pathologist, they may give you a Gleason 7, they send it to another, they give you a Gleason 8. And it's about 70% of pathologists agree with each other. It's not like 95%. And it's similar with MRI. But you have something a little bit more objective where you can take that tumor and analyze the genes in it to be more, precise. And what this is, people call this a heat map. So this is about 18,000 men. Each column here, all the way across, is a patient. So there's 18,000 columns here. Each row here is some type of gene score. The top one's Decipher. It's a commercially available test, but there's a variety of these just to illustrate. And despite all these men having high-grade prostate cancer that we would treat exactly the same, we would think about them the same, their gene expression is very different. Blue meaning it's less aggressive, red meaning it's more aggressive based on the gene expression. So again, looking at that 100 guys, not all of them are the same, despite them having, let's say, the same Gleason score. And so what I'm showing you here is the latest national guidelines, the national guidelines that most doctors either closely follow or it frames the way they treat. Is called the NCCN guidelines. And there actually is patient versions. If you Google this, there's patient versions for you to read, but there's also versions for physicians. And there's three main gene expression classifiers out there: the Decipher test, the Polaris test, the Oncotype test. And I'm not paid by any of these companies. And what you see is that we often will say, what has the best evidence for use? And the Decipher test pretty clearly is now, in the last couple of years, sort of shot way, way past these other tests in terms of it's now been validated, as I'll show you, in a whole bunch of big clinical trials. And so this now is, by far and away the most common test ordered. And I try to make sure patients know this, because sometimes practices will just be, let's say they've used one test for many years. They're just, the docs, or maybe it's their pathologist or their administrators, are too lazy to switch. And these tests are not all equal. Some will try to just say they're all equal. But if you're going to get one of these tests, this Decipher test is right now the most validated test. And for you guys to understand the Oncotype test, what's interesting about it is it gets a lot of buzz because there's also an Oncotype test, the same name, in breast cancer. And it's actually a very good test. It was made in big clinical trials and validated. But the one for prostate cancer was made after, and it was sort of haphazardly made, some people feel. And they tried to validate it in this study called Canary Pass. It's a big active surveillance study in men with low risk, and basically it failed. The test was not accurate. And so it gave a lot of people pause, should they be using it? And that's why it got that category 3. Polaris, again, what's interesting is this is a test that was made in breast cancer, and it measures how rapidly a cancer divides. It's called proliferate. And they just said, hey, well, let's try to test it in prostate cancer. And unfortunately, they've never really tested it in any prospective or clinical trials to really know, does it work? And as I said, Decipher now is recognized by pretty much every guideline. It's been validated in lots of randomized trials. And not that these names or numbers of trials should mean anything to you, but it's been tested in guys with low risk, with intermediate risk, with high risk, guys after surgery, even metastatic patients. So it's been put through the gauntlet. And what we did, this is back in about 2018, is we wanted to help providers to say, well, okay, how do you actually use the Decipher test to help make treatment decisions? Because going on the far left here, your doctors will be very familiar with these NCCN risk groups and kind of what the recommendations from these risk groups are, whether it's to do active surveillance or to do surgery, etc. And if you get the Decipher test, it'll come back as a low risk, intermediate risk, or high risk. And to be very simple and easy to use, we just said add up your NCCN risk group point to your Decipher point, and you get these points here. And you can then use this as it's called the clinical genomic risk groups, rather than the NCCN risk groups. These are the clinical genomic risk groups, and you can then use these and look back at the NCCN guidelines and say, well, how should I more accurately treat patients? And what we showed in this big study is that, again, going back to that metric, if a coin flip is accurate half the time, in this data set we had, these NCCN risk groups were right about 65% of the time. And if you use the Decipher test with it, it's about 85% accurate. So it's not 100%. There's probably no system out there in any cancer that's 100%, but it's getting a lot closer to that. And so this helps patients often when you have a decision to make about de-escalation of therapy. Maybe it's to not give hormone therapy, or to not give long-term hormone therapy, or maybe to do active surveillance and not treat. This is going to give you a more accurate assessment, irrespective of your grade of your cancer. So sometimes when I show this, the pathologist will get a little angry because I'm sort of saying, hey, this Gleason grading doesn't work that well. Or the radiologist and saying, hey, the MRI is helpful, but it's not perfect. And there's sort of a new era coming, okay? And some of this is already here. There's a lot of information on this. Is a pathology slide of what cells look like. There's a lot of information on this slide that a pathologist either right now doesn't know to look for, or is not part of Gleason grading. There's a lot of information here. Same on an MRI. This is an MRI image. There's a lot of information here that probably goes unrecognized. And I joke often, but Amazon, for those who use Amazon and Amazon Prime, it knows me better than my wife does. It knows when I need a refill on everything. How it does it, it's got unbelievable amount of data and trends and patterns that maybe my wife doesn't even recognize. And similarly here. And so the question is, can we move from, people will call these, if we put it in a negative context, genetic test, tissue destructive, right? You have to take that biopsy or that surgery sample, we'll oversimplify, grind it down and extract the genetic material. So that tissue has now been used. With this AI, you just need to take a picture. This is it, just from your biopsy, they digitize it, and they can then analyze it. And it also, the speed at which this process on the left may take weeks, 2 weeks, 3 weeks. It's basically how fast can a sample be digitized or sent, and it's usually just a couple days to get a result. And so what my team with a company, it's called Artera AI, we wanted to ask, can we use the information on these slides, and using all the supercomputer, people about machine learning, can we train it in patients that have been treated on these big clinical trials, where we know, did these men develop recurrence? Did these men develop metastatic disease? Did they die of prostate cancer or not? In a very rigorous, these trials followed men sometimes for 20 years. And so we sought out, can we do this to make the first test or biomarker to predict how aggressive a patient's prostate cancer is, beyond what a human can do? And so what I'm showing you here on the left, these are men with sort of, we call it intermediate risk prostate cancer. Think of it as like a Gleason 7. And this is for distant metastasis. These are, how accurate is this to estimate, did a man develop metastatic disease? Okay. If you just use every variable that's in our NCCN guidelines, your grade, your PSA, the T stage, well, let's say here it was about 70% accurate if you use these variables to estimate, will a man develop distant mets or not? If you use this artificial intelligence model, again, we got to love our acronyms here, that it was about 84% accurate. Okay, so adding the AI, basically the blue bars are higher than the gray bars. Adding the AI to our usual information that we get is more accurate to estimate, does a man develop metastatic disease? And this was in one trial here, and this is in trial of high-risk prostate cancer here. And as of earlier this year, it got added to the national guidelines from this work we did. And so it's now has level 1 evidence because we validated it. It's now been validated in 8 trials. So what I was telling you at the very beginning of the talk, it took about 15 years to do all that work with the Decipher test. And in just about a year and a half, we validated and developed this test with artificial intelligence. So it's really remarkable the speed at which can be done. But probably the thing that hit the news the biggest is, yes, it's really important to be able to tell a patient, is your cancer not aggressive or aggressive? But kind of the holy grail of precision or personalized medicine is, I'm going to give you this example, and we call these predictive biomarkers. Predictive. And what that means is, can we find something about your tumor that if we give you a certain therapy, so we'll call it a drug, that if you don't get the drug, like pretty much every guy develops recurrence, but if they get the drug, they're basically cured. But if you don't have that feature, whether it's that mutation or whether it's some specific thing about that tumor, that drug doesn't really help you. To give you an example, if for some of you guys may know something about breast cancer, is some women with breast cancer have what's called estrogen receptor positive breast cancer. And those women, if you give them something that blocks estrogen, it really helps them a lot. But if their tumors don't have that estrogen receptor, giving them that therapy does nothing. Okay, so the question is, I told you earlier that we give almost all men with higher grade prostate cancer hormone therapy when we give them radiation. But I said it's about, 1 out of 18 guys has a benefit. Okay, now while that's a good number, that's 17 guys who don't benefit. So can we figure out what feature is telling us which of those 18 guys benefit and which ones don't? And so we went back and we said, okay, well, now let's have this artificial intelligence, this machine learning. Can we say, can you identify features, things on this slide of this tumor that tell us which men benefit from hormone therapy and which don't? And we used a whole bunch of randomized trials of thousands and thousands of men. And this would, if successful, would be the first time ever in history that a biomarker or a test in prostate cancer could tell a man, do you need hormone therapy or not? There's no test out there that has ever been validated. Many have attempted to, but none have ever been validated in a randomized trial to say we can predict this. And so this was just published in June, end of June, in a big team that I helped lead, but again, people across the country and through this Artera AI company to do exactly what I just said. And so what we found was that in men that we normally give a short-term hormone therapy with our radiation, with this biomarker, okay, with this test, we could identify about 2/3 of men that we normally would say you should have hormone therapy will not benefit. About 1/3 of men we currently recommend that course of hormone therapy would benefit. And so to kind of show you what this looks like, these curves here, it starts at 0. And as it goes up, that's the risk of developing metastatic disease. And on the x-axis, this is time since the guys were treated. And so in the overall trial, not using any of the AI, nothing, just all the guys enrolled on this trial decades ago, if you just got radiation, you had a higher rate of developing metastatic disease in the red curve. If you got the radiation plus that short course of hormone therapy, you had a lower rate of developing metastatic disease. And that's why, this 4% benefit is why the national guidelines say we should give hormone therapy. Okay, but then let's apply this AI test. So right in the middle here, these are the guys, the 1/3 of guys that had a positive score, meaning they're likely to benefit a lot. And look at this. So if you do just get the radiation versus if you add that hormone therapy, you now over double the benefits. Instead of 4%, it's now over 10% benefit or reduction in metastatic disease. And very few of these guys develop metastatic disease long term if they get the radiation with hormone therapy. But if you look at the guys here and this is 2/3 of the guys, okay, that had a negative score, there is no difference in these curves at all. So whether we gave the guy hormone therapy or we did not, they're just as likely to have the same outcome. So why give them hormone therapy for the side effects it causes? And this is the same exact thing. The only difference here is looking at men dying of prostate cancer rather than developing metastatic disease. And very similarly, if you look at all patients not using any fancy tests, adding hormone therapy does reduce the risk of dying of prostate cancer. But I mean, look at the separation here. If you have a positive score, at 15 years, if you got the radiation, the hormones, only about 2 to 3% of men died of prostate cancer. If you just got radiation, it was over 10% of men did. But if you had that negative score, there's basically no difference, about a 1% difference in dying from prostate cancer. So it really didn't help these men. And so I want to make sure there's time for you guys to ask questions, but to put all of this together is when I'm talking with patients, I just had my clinic day the other day, is half the conversation is sort of the advances in radiation therapy that I started with, where we can give 5 treatments, very low rate of incontinence. Now, thanks to using a rectal spacer, a low rate of rectal side effects. With modern radiation trials now, it's about 1 out of 10, we'll say 10-15% of men will take a hit, but much less than it used to be with erectile function. It's a lot more convenient. And of course, it's guideline recommended and insurance covers it. The other side of the story is the hormone therapy. And I think whether you're using tests like Decipher to see, do you have a less aggressive tumor? Or now with this Artera AI test, to see, do you need hormone therapy? We're sort of in this new era of truly personalized therapy. And I just gave a talk in Washington, D.C. to patient advocacy groups. And I always like to make sure patients see this. So I'm putting this up here. And I put it up here about, I'm sure you guys are familiar, maybe some of you have had this procedure, of things like HIFU, high intensity focus ultrasound, and there's about 20 of these products out there. And I put this up here and because a lot of patients don't realize that actually the FDA has continued to deny the FDA approval for the treatment of cancer. These are approved for the treatment of enlarged prostates or prostate disease, but not cancer. And that NCCN guidelines, which is made up of a lot of people, still does not recommend the treatment. And so usually my patients here, and I don't know how it is in California, but out here in the Midwest and Florida and the Northeast, guys are charged about $30,000 cash. And the trials are pretty consistent. It's about half of guys will develop a recurrence in 2 years, and some still experience these side effects. So I tell patients, if you want to go this route, please make sure you do this on a clinical trial, because prostate cancer is the most common cancer in men, and you should just ask yourself, why on earth is something not in the national guidelines, not FDA approved, and you're making me pay cash and my insurance company won't pay for it? So with all of that, I appreciate so much the invitation to speak to you guys, and I will more than happily take any questions you have.
Dr. Spratt, that was absolutely wonderful talk. Thank you. It answered so many of our questions. The advent of AI and everything in our lives seems to be exploding. Do you have any stock recommendations?
I wish.
Oh my God.
I wish. You don't want my advice on that. So, but yeah, I wish I invested in Microsoft because they own the Chat GPT, or they help fund the Chat GPT, and it's apparently Microsoft just is booming because of it. So,
well, again, thank you very much for the unbelievable. There's a new spacer on the market. Have you had any experience with it?
So there's the Space OAR by Boston Scientific, and then there's something called Berry Gel that's sort of a we'll say relatively similar. I don't really, I view them as relatively similar. There's another one that is called BioProtect, and again, I'm not. What I will say for transparency is I have served on advisory board for Boston Scientific that makes Space OAR. I did not receive much money at all. So but I will say that to me, Berry Gel and the Space OAR, I kind of view as similar, but this newest one called BioProtect, I don't think most docs are going to want to use it. It's a balloon. You have to have almost like a mini surgery. They do this dissection and to insert a balloon and stitch you up. It kind of defeats, it is just my viewpoint, defeats the purpose. And the whole point of putting the gel is to spare you side effects. And if we're going to dissect out and put a balloon and stitch you up, seems kind of invasive to me. So.
Well, it seems to me if you got some finger in somebody's rectum, they should at least pay you. So.
Yeah. Ira, I see your hand up.
Yes, I do. Thank you very much for the talk. I understand that Artera AI has a different model as well, which could indicate short-term or long-term hormone treatment. So could you talk to that?
Yeah, absolutely. I was trying to decide how much to pack in, but so we just presented this a couple months ago. So you're on top of it, Ira. It was just presented. It's not even published yet, where we've done similar work and been able to very accurately estimate men with higher grade prostate cancer. Do they need, let's say, 2 years of hormones versus just 6 months? And it works very well. So that's something that they hope to be released for clinical use in 2024.
Are you are you able to quantify the amount of time for hormone treatment?
Not more precisely than either 0 versus 6 months or short term, or the short term versus long term, like 2 years. And the reason is we're somewhat limited by the trials that have been done. They usually pick 2 time points. They don't do a 4 month, 5 month, 6 month, 7 month, 8 month. So I think that often where I personalize, if let's say I want to give a guy 18 months, if I was just looking at like the textbook answer, we sort of would look at a lot of personal factors about the patient, their age, do they have heart disease, how aggressive is their tumor, etc. And, some guys I'll give 9 months to. And so that's sort of where the individual aspect of it, you got to make for each man.
By the way, I read about what you and Dr. Kishan did with the MARCAP, to extend it, but I guess that's as close as you could get. But probably Artera AI will do better than that, hopefully.
I think it's doing great things. So appreciate it, Ralph.
Hi, thank you so much, Doctor. I really appreciate all the information. I was recently diagnosed. My Gleason score is a 347, so I'm an intermediate. It's localized. It's in the lower left portion of my prostate. My doctor and I decided to go on active surveillance, which I like. It gives me some time to really talk to people like yourself and understand what my treatment options would be. If I ever got to the point where this therapy would be something I chose, and it is localized, do you have any data on after I go through that therapy and we stabilize or eradicate that area of cancer presenting itself somewhere else in my prostate later? Is that something like, is this whack-a-mole, or is this kind of a what's your, and I know you can't guarantee anything, but what have you seen?
Yeah. So obviously there's a lot of caveats. So I guess I need my own disclaimer, but in general, if let's say right now, because I can't, like, if you were to eventually get treated, you might have a more aggressive cancer. So, but if we were to say right now with a Gleason 3+4 cancer, Gleason 7, is your chances, we'll say I'll give you a 10 and a 15-year number. If you were to say, let's say have radiation therapy, that SBRT, your chance of developing metastatic disease is in the very low single percentage points in the next 10 to 15 years. Your chances of dying of prostate cancer in the next 15 years is about 1 to 2% tops.
Yeah.
And it's going to be very similar whether you choose to have it removed or radiation, because that 1%, 2% is probably some cells we can't see no matter what imaging we get for you that's out of that area.
Understood.
But some of those men, a subset, can be cured actually if we do targeted radiation. I didn't talk at all about these new PET scans, but if they haven't, Ralph, gotten you either a Decipher test or a test like that, that's usually something we get for men with Gleason 7 who want to be on active surveillance. We get one of those tests to make sure it's a less aggressive Gleason 7 tumor.
And they did do that test, and I wish I had my results with me. The only thing I remembered from it is I was down in the blue. So it was like a good number. That's
a good number. Blue is good. So that's very reassuring. That's very reassuring.
All right, very good. Thank you so much for all your time. I appreciate it.
Absolutely. Hey, Bob?
Hi, doctor. Can any of this be applied to someone who had surgery 10 years ago, who's in a slow recurrence that did not show up on a PSMA PET CT so far? Okay. Would any of this apply to how to go forward from here?
Yeah, it would. So if you don't mind me asking, Bob, can you tell me what the PSA is most recently?
Sure, PSA is 0.65.
And when was the surgery?
10 years ago.
Okay. So it's a great example of a lot of people, when they hear the word recurrent prostate cancer, they think, oh, it must be so aggressive, it's recurred. It's not true. Yes, there can be aggressive recurrences, but similarly, there can also be recurrences that are very indolent and slow growing. So in 10 years, a PSA of 0.6 is never going to harm you. Like if it doubled in another 10 years to, even if it got up to 3.0 in 10 years, I wouldn't even treat it, Bob. It's not like you will never die from PSA. You will die if you develop metastatic disease and it's taking over your body. And so what I would say, expert, thoughtful physicians will think of active surveillance in the recurrent setting and monitor. So the test that the Decipher test is something I would get. And we've actually analyzed tumors that are up to 30 years old that they've had surgery on, and it's still very accurate. My guess, Bob, is that your Decipher score will not come back high because, but I would keep monitoring it, and I'd get a Decipher test, I'd keep monitoring it, and I'd get until you can see it on an MRI or a PET scan. And if you don't mind me asking, Bob, how young are you?
78.
68?
78.
78. All right. So, I would say if it were me, I would keep monitoring this until they saw something because it's probably something low grade. If you haven't had an MRI, sometimes what it is these PET scans, the recurrence is right where they did the surgery next to the bladder, and those PET scans light the whole bladder up and you can't see the little spot. So I don't know if you had an MRI or not, or if you can, but they might see it on that. And if they do,
Okay, so the Decipher test would be on the original pathology slides from
from your actual prostate. Most hospitals will keep your either your biopsy or your prostate specimen for decades. Now, some, if it's a smaller community hospital, sometimes they'll do it for 10 years. Many will hold them for decades and decades. So you can ask, but usually they keep them housed somewhere. So it would be your actual prostate that was removed. They would send it off for.
Okay, very good. Doctor, thank you, thank you, thank you, thank you, because that's the door. You just confirmed the door I was coming out of, resisting treatment at this point because it's so slow and it's so many years out. So thank you for your confirmation, at least where I stand right now. I appreciate that immensely.
My pleasure. Brian?
Brian, you're muted.
You're muted, my friend. Brian, you got to unmute.
There you are. Okay. I'm the techie. I don't know how to unmute. Okay. Want to wrap my head around with two items. One, if I understand you correctly, the contribution of AI in your research is to essentially be able to analyze these tissue samples with sufficient accuracy that it becomes a prognostic biomarker. Is that correct?
Spot on.
Okay. Then and then you were able to analyze all this previous data because the AI technology, it allows you to go deep into vast, huge databases. And instead of having to learn your statistics, AI does it for you, essentially.
So, yeah, sort of. What we're able to do is that, one of the problems, like, let's just pretend I wanted to take PSMA PET and I wanted to say, does it really help men? I can't go back to 20 years ago because no one had one, right? But what we're able to do here is we can say all we need is a single, it's called an H&E slide, that on many of these trials are banked. And because they're banked, we have all the outcomes of these patients. So we can then validate and understand how the men actually did.
Got it. Thank you. And then the second is totally different, is I'm a fortunate champion of successful, so far, SBRT plus SpaceOAR at UCLA. But their ViewRay is temporarily out of commission because of the problems. Are there other devices, any systems that, or is SBRT out of the question for the moment?
So what I will say is, so he's talking, for those that don't know, it's called the Meridian. It's SBRT, like I talked about, but it's built in, it has an MRI, and there's some other things about it. The company, unfortunately, actually, we were in the process of buying one, and the company filed for Chapter 11 bankruptcy and now Chapter 7. And I don't know, Brian. I talked to their group and their chair and Amr Kishan. I have a feeling the company will be gone. I think, but what I think there are other solutions that are going to be available that actually the benefit of that MRI is high. I will say it's highly debated in the community. And so I think there are ways to get similar benefits to what that MRI, the Meridian, achieves with some other, we'll call it fancy tricks that we can do. And so, there's a machine made by Varian. Actually, we just presented the data that on a normal linear accelerator, they've now souped up their imaging. It's basically just as good as a diagnostic CT scan, and it's super fast. It's like 6 seconds. And so I think there's going to be plenty of things to add that. And I would say the benefit of that MRI was small, but there. And it's all about continual incremental benefits, right, to make it safer and safer. So I think that with in expert hands, with a spacer, with SBRT, and I can't emphasize enough, in expert hands, like at UCLA, that team is excellent. They are excellent.
So even though I've been recommending it to my in-law to get the SBRT treatment, I can simply refer him to you now instead of to UCLA, and he'll get the expert treatment.
I am more than happy. I have people that travel around the world to see me and treat, but at the same time, what's best for the patient. So,
but the treatment's not dead is really all I was checking. Thank you very much. I really appreciate it.
Dr. Spratt, do you think the PSMA precision guided SBRT will ever come to be?
Yeah, so we've talked. I think that it will be a component of therapy that where we, and actually we're trying to launch a trial. It will sort of answer your question, where in men with high-risk prostate cancer, we pretty much almost always give ADT. We're actually working, hopefully they'll approve it, with Novartis. Some of you may have heard of something called Pluvicto. It's sort of an injectable radiation that targets cells with PSMA on it. And so what we're doing is we're going to give this injectable radiation as well as SBRT to the prostate. Because the reason men with, let's say, guys whose PSAs are 50 or 80 or 90, the reason that they most often recur after radiation or surgery is they have microscopic disease somewhere that maybe the scan doesn't show. So we're combining them without giving any hormone therapy to say, why is hormone therapy the only systemic treatment as the backbone? And men, no, I don't say all men hate it. I mean, it's an annoyance, but it's not that men usually love it. Can we combine the Pluvicto with the SBRT without hormone therapy and achieve similar, if not superior, results? So I think we use PSMA all the time to target areas within the prostate to boost to higher doses, or to lymph nodes and bone mets. So, hey, Ralph, you got another?
Yeah, and I hope this is an appropriate time to ask. The other issue I have is I'm 64 years old, and my prostate through the MRI imaging was 119 grams. And I see a lot of information out on the internet about prostate reduction therapies and things like that. Is there any truth to any of that stuff, or is it just my prostate just going to be enlarged for the rest of my life?
So an enlarged prostate itself is not a problem. It's how functionally it affects you.
Okay.
Right. So if your prostate's the fist, and I'll grab my pen here, this is your urethra. Of course, let me just take this stupid blurry background off. So this is the urethra, your prostate's around it. You can have a prostate that's enlarged, but not pinching that urethra. Okay. It's not a big deal. Some guys, and many guys, as you age, it starts squeezing it, and we wake up at night, you wake up 2 times, wake up 3 times.
Yeah.
So I think that in general, for guys that have reasonable urinary function, a reasonable stream, let's just say if you get radiation therapy, it kind of locks in. It won't continue to grow. Basically, your prostate won't continue to grow. If you ever need, or if you go on hormone therapy, it will shrink your prostate by about 30%. Mm-hmm. Now, what's interesting is most of the time that doesn't actually help men's urination flow, because it doesn't necessarily shrink near the urethra, it shrinks on the outside.
Okay.
But there's a lot of procedures. I would say the one I like the most, that or my patients, I should say, seem to prefer the most, if you have an enlarged prostate that's causing a problematic urinary symptoms, is called the HOLEP, HOLEP, HOLEP. It's a holmium laser. I like that a lot more than the traditional TURP, the kind of rotor-rooter. In people that do the HOLEP procedure, it's a holmium laser that will sort of allow you to pee easier. But I don't think your prostate's not that enlarged.
Okay.
It's enlarged, don't get me wrong, but like it's not 300 grams.
Okay. All right. Well, thank you very much for that help.
Yeah. Bob?
Doctor, follow up to what I asked before. If we eventually get a hot spot or hotspots on a PSMA PET to be treated for those spots only, I know people who've had that where they gave them ADT in addition. Would this Decipher test help to decide
Yes.
whether the ADT would add anything to it, given its side effects?
Yeah. It really so the Decipher test definitely may help. If it comes back low, I personally would not be adding ADT. But it also depends if and or when that scan shows something, right? If it shows something in a bone, it might be different than if it's something just in your pelvis. Again, for me, if it was something in your pelvis with a low or even what's called intermediate Decipher score, I wouldn't give you ADT. I mean, I don't think they minimally benefit you.
Okay.
Ira?
Well, first of all, you and Artera AI really accomplished a lot. Do you, and I know your hands are full, but do you have plans for other activities out of Artera that we would benefit from?
Yeah, so there'll be continual work, like we're actively working on something. So all the work that I showed you is kind of newly diagnosed from patients' biopsies. We're working now on patients who have chosen to undergo surgery, looking at that pathology to see if we can personalize men after surgery, or if they've recurred, do they benefit from various treatments? And we'll be trying to expand it even into metastatic or advanced prostate cancer settings. They will, and again, hopefully none of you guys will need this, but we are also pivoting, or not pivoting, we're adding on as the company's growing, work in breast cancer and some brain tumors and head and neck cancer to sort of do comparable work with similar teams. But there'll be more work in prostate cancer for sure.
How, I'm just thinking out loud, how does the cost of Artera AI compare if somebody wants a second opinion, just a second opinion who's diagnosed, they're not really worrying too much about hormone treatment, but they want to see if they have a 7 or a 6 or whatever it is. So, would they want to send it to you because, is the cost much different from a quote, a real pathologist?
Yeah, so the Artera AI test won't give you the Gleason grade because it's sort of fundamentally saying we don't think it's that accurate. But the test just got, I was told, Medicare reimbursement approval. So you have Medicare, I'm told the test is fully covered. The test, I think, is far cheaper than the genetic tests. Like the genetic test, like Decipher and things, I think are $3,000-$4,000. Now, usually the out-of-pocket cost, if you have Medicare, things like that, it is low. But I think the AI test will be more like $700 if they're, but don't quote me on this. My understanding is right now, because they're a new company, I don't think they're actually like they're not sending anyone to collections. And that's how the genomics companies did it too. They have to legally bill insurance, but if they don't cover, they don't actually, it's basically a free test. And that's what the genomics companies did for the first 5 years or so, just to enable use. But I don't think that's something that's like, can be publicly stated. But
By the way, I noticed that Artera can be done in 48 states, but not California and New York. And so we have support groups at this location. So we like to send our men to Artera. So when do you think that might happen?
That's the first I've heard of that. I will reach out to them. I had no clue that couldn't be.
That was on the website. At least a week ago.
Interesting. I will reach out and I'll email Brian. I think we were communicating. I will reach out and get you an answer to what's happening with that.
Okay, thank you.
Russ?
I guess I have to remember to unmute, huh?
You're unmuted.
Well, I wasn't there for a couple of seconds. Hey, great presentation. Thank you very much. I'm currently an SBRT patient and went through and utilized Artera to basically less than a 2% probability, and basically removed all of the ADT treatments from my program. So thanks.
Good. Good to hear.
I really didn't want to do the hormone part, so it worked out well. So long term, I guess I'll get back to you. How's that?
Good. Well, that's great. And where's the photo from?
A photo I climbed. That's Aconcagua in Argentina.
Okay, I was gonna say that's great.
But the one question I kind of had about all of that was, you mentioned Microsoft, and I was kind of curious, do we know if our Artera is using Microsoft's AI engine?
Nope. It's all proprietary. It's everything they made.
Okay. All right. And the reason why I asked that is this came up in some discussions we've had in the forum prior to this for a different reason, that what information you feed the AI is going to affect its operation. So I was kind of curious whether it was a privately held and fed engine, which apparently appears to be true.
Yeah, it's all privately held. It's not the Google's where it probably has ungodly amounts of information on all of us. But also the difference is the FDA does not currently allow continuous learning models, meaning that on Amazon or on YouTube or things like that, it's constantly learning.
Yeah.
This has to be sort of a locked model that they say they can't change it every day. So that, like, your test doesn't go into changing what, like if you sent your sample in a year from now, it'll have the same score. Now they can resubmit at intervals and say, hey, we've improved our model, but it's got to be very highly regulated, that a lot of the commercial business models don't have to be. They can kind of change them constantly.
And that makes perfect sense. I mean, it is what information you fed it.
Correct. Yeah.
And if that's not controlled, the reason for that was another reason of other applications for medical with regards to AI. Controlled models are much better with regards to that. It was kind of a side effect other than me being a patient, but I work in AI, and a side question with regards, that actually makes me feel even more comfortable about the test. How's that?
Yeah.
Thank you very much.
Absolutely. And, hey, Mark, I saw some questions in the chat.
Dr. Pratt, thank you. This has really been a sensational. You were mentioning HOLEP. Do you know what the incidence of finding incidental prostate cancer when you remove an entire gland like that?
Well, the HOLA shouldn't remove the whole prostate. I mean, it should remove a very small amount near the urethra.
No, it removes a great amount, even away from the urethra, and they're finding the pathology on that is just about what they've always thought. It's not anything spectacular, but I just wondered, HOLUP is a really, really hard thing to learn, but once you learn it, oh my goodness, then you become Daniel Spratt.
Well, it's a great procedure. So Mark, I see questions in the chat about a size limit.
Right.
Great. Yeah. So each center, I would say it's the comfort level and expertise of the doc. I would say sort of, if you were to ask like the run-of-the-mill radiation doc, they probably would say 60 grams. I usually, my limit's closer to about 150 grams. So it's going to be highly dependent, I guess, on the expertise of that doc. But to me, under 60, no problem. To me, under 80, no problem. But I could see some sort of docs that are not very high volume might steer away from it when you get up above 60 to 80.
Okay.
And the prior TERP, it shouldn't, if your symptoms are well controlled, meaning that if some guys have a TERP, but they still have a lot of obstructive symptoms, like the TERP basically didn't work, they probably wouldn't want to give you SBRT. But if you had a TERP and you've got a reasonable stream or flow, no worries. I mean, I usually want to wait at least 4 months after a TERP before I would give radiation, but no problem at all. Now, again, you will find the average doc is going to be ultra conservative, and they'll want the stars to align. And I don't know in California, but there are still, we just put this paper out, there's still about a third of practices out there that still give the 8 weeks of radiation. And they do it because it pays the doc and the practice way more money than 5 treatments. So sometimes you want to make sure you find a practice that they'll use those things you're mentioning. Oh, your prostate's 70 grams, or oh, you've had a TERP, we're going to give you 8 weeks of radiation. I don't really think there's data for that, but that's sort of their reason to give you a more expensive course of radiation.
Okay, it's like a size of like 90 something and a TERP. Would both those then kind of steer you away, or still not?
If you're peeing well,
yeah.
What some guys will do is they'll say, hey, let's give you 3 months mark of hormone therapy. There's a hormone therapy I'll put in the chat called relugolix. It's an oral hormone therapy that's super fast on and super fast off, so it doesn't have this long tail of suppressing your testosterone. And so some guys will just do about 3 months of that just to shrink their prostate down. And it'll usually shrink it by about a third, so it'll probably bring it to about 60 grams. In 3 months, I know people don't love hormone therapy, but 3 months fast on and off. Again, I've never been on hormone therapy, but I've treated over 2,000 men. Most guys, it's not the biggest deal to be on 3 months. It gets to be a real big deal when you're on it for a lot, month and month and month and month and years and years and years.
Right. It might surprise you, Dr. Spratt, to realize the best TERPs were on Proscar at the same time, and I'm sure you'll get that meaning. So
yeah.
Okay. I mean, that would be a good trade-off versus if the only other choice, if radiation wasn't going to work, be appropriate, then it would be surgery. So then a 3-month ADT would kind of help offset that.
Yeah.
Okay. Great. Thank you.
Hey, Neil.
Let's take one more question. Is there anybody else that has a question? Raise their hand. I'm going to make one last call and we'll let everybody go to dinner. With that, Dr. Spratt, I want to thank you for an outstanding presentation. I think it's one of the best I've seen in a long time. with that, for those of you watching at home, please visit our website, www.prostateforum.org. That's www.prostateforum, as one word, .org. We are based here in Orange County, California, USA. Please feel free to sign up for our newsletter and for our information to you about future presentations and support group and information group meetings. And you'll find that all on prostateforum.org. Also, please feel free to help us with donations, especially of cars. We take car, truck, RV donations. And we thank you all for joining us tonight. Thank you all very much.
Thank you, doctor.
Thanks,
Thank
Doc.
you guys. Best of luck.
Thank you, Doctor.
Thank you so
Doctor.
much.
Amazing presentation.
Take care.